Thank you for joining us for Health Talk. Our special guest for this program is Dr. Amy Johnson, bariatric surgeon at Pikeville Medical's Weight Loss Surgery Department. Dr. Johnson will discuss different options for weight loss surgery, and you will receive tips from a dietitian to help you prepare for surgery. So let's begin now by meeting Dr. Amy Johnson.
Welcome to a discussion on weight loss surgery. My name is Dr. Amy Johnson. I am a board-certified general surgeon and a bariatric surgeon. I've been doing bariatric surgery for roughly 10 years. I went to medical school at Wake Forest School of Medicine and did my training, my general surgical training at Wake Forest University Baptist Medical Center. I was an active duty surgeon in the military for some time and moved here to start a program. Today we're going to discuss a number of issues, the primary issue being obesity and the disease of obesity. We need to go through a number of definitions in order to understand fully why we do what we do here at Pikeville Medical Center. We need to discuss the causes of the epidemic of obesity. We need to discuss obesity treatments other than weight loss surgery, and then we will discuss weight loss surgery in some detail, outline criteria for weight loss surgery, outline the risks and benefits of weight loss surgery, and talk a little bit about our program here at Pikeville Medical Center. It's important to understand what we're talking about here, and that is that we're talking about a disease process called obesity. We define obesity specifically by BMI. BMI is body mass index, and it basically takes your weight in kilograms and divides it by your height in meters squared. It's a fancy term, but basically what it ends up doing is allowing us to compare patients and their heights and weights so that we have an even number to look at healthy weights versus unhealthy weights. When we talk about normal weights and normal BMIs, we're talking about BMIs between 18.5 and 25. When we talk about overweight patients or people, we're talking about BMIs between 26 and 30. And obesity BMIs are 30 and up. We have a special class of obesity called morbid obesity that is a BMI of 40 or greater. These numbers are used around the world so we can compare people everywhere and we can talk to each other as healthcare professionals and we understand how obese somebody is. The scope of the problem of the obesity epidemic is sort of unprecedented. We know that approximately 40 million Americans in the United States are obese. That is approximately 34% of the population. When we look at Pike County, we see an average of approximately 36% of patients who are obese. When we combine overweight and obese patients in this country, we find that 2/3 of all people in this country are either overweight or obese. And that's a really big problem, particularly when we talk about the consequences of obesity. Approximately 4 million Americans are morbidly obese, and that's that number that we talked about that was a BMI of greater than 40. Approximately 80% of all people who are diabetic are obese, and approximately 70% of all people who have coronary disease, hypertension, other forms of cardiovascular illness are obese. We know that there is a direct link between obesity and many cancers. We have a lot of information on breast cancer and colon cancer as being directly linked to obesity. The hard part of all this discussion is what the cause of this epidemic is. If you look back 50 and 60 years ago, we have normal weight people primarily in this country with a few overweight and very few obese patients. We have come through 50 years and find ourselves with the majority of people overweight or obese. And it's a frightening medical problem that has sort of gotten away from us. We understand that there are genetic components to this disease, behavioral components to this disease, and environmental components. When we look at genetics, we understand that there are approximately 1,200 genes that regulate our weight. In a normal person, there are all of these genes working together to continually keep your weight at a certain level because we need a certain amount of fat, a certain amount of lean body mass to work well on a daily basis. We have done something environmentally. We're not positive what this is. We know that high-fat diets, we know that diets that are very high in processed foods cause a problem with these genetics and cause us to increasingly add to our fat mass. So we know that in general, when patients get morbidly obese, even if they eat 1,800 calorie diets, they will not lose weight if they are still eating high-fat, high-processed foods. So we know there's something about that diet that causes a huge problem. And in today's world, we know very well that the primary source of food, particularly food that's cheap, is highly processed and highly fatty. We also know that what we've done in the last 50 years is gone from a country that works manually and that is very active to a country that drives everywhere, even to get our food, right? We go to the McDonald's, we drive around the McDonald's, we get our food, we drive home, and we sit on the couch and eat it. We've expended no energy in getting our food source. And 50, 60, 100 years ago, we had to go out and shoot our dinner and dig up our dinner out of the garden, which was activity that we no longer do in this country and in many parts of the world. So we've got a real problem. It's multifactorial, and we're trying to get to the bottom of it. A little bit about the consequences of obesity. When we think about the consequences of obesity, we think things like diabetes and hypertension. However, there are innumerable problems that go along with obesity. We have multiple cancers that are directly associated with obesity. We know that coronary disease, congestive heart failure, stroke, gallbladder disease, osteoarthritis, sleep apnea, all are direct consequences of obesity. We also know that there are more, and this is only a short list of problems that are consequences of this disease process. So we treat obesity here at Pikeville Medical Center because we want to make people healthy and get them out of the sort of the cycle of starvation followed by reweight gain, starvation followed by a little bit more reweight gain, so that all that dieting does is cause an increase in weight over time. We treat obesity in this country because we really can't afford not to. There are estimates of $500 billion being spent on obesity-related conditions alone in this country in 2020. So we have a real problem that's not going to go away. It's not going to get better until we have a real solution to the problem. The driver of this economic freight train is diabetes. Diabetes is very expensive to treat. It is taxing on the individual and ends up being a fatal problem. We know the obesity treatments in the world today include diet, and that's a word I'll talk about in a moment, and exercise and drugs. Diet and exercise are excellent ways to keep yourself healthy. A good balanced diet that's low in fat, low in carbohydrates, and high in protein is an outstanding way to keep yourself healthy. Exercise is an excellent way to keep yourself cardiovascularly fit. Neither one of these alone have really proven to be that effective in weight loss for someone who is already obese or morbidly obese. And I think that many people know this, many people have experienced this. We don't have a lot to offer when it comes to obesity treatments. It's hard for primary care physicians to offer anything more but this, low calorie, low fat, high protein diets with exercise. The problem is people get very frustrated because they really don't see much in the way of success. So what I see my patient population do is go to fad diets, so the cabbage diet, liquid diets, those kinds of radical diets that cause very quick, profound weight loss. The problem is when they start eating again, they gain all of their weight back and then a little bit more. And that's, again, your genetics working overtime to get back to that weight that your body thinks it needs to be. In general, medicines are effective while you are on them. The problem is we can't keep patients on medicines long, particularly the medicines we have out there now, because they are dangerous to the cardiovascular health of the patient. So it gets us back to that discussion you have with your doctor, and I know many doctors have discussions with their patients about their weight and how best to stay healthy, and that's weight loss. It's a very frustrating experience for both patient and physician. We can all try to change our behavior, but in the end, when you find that you start eating a little bit after a fad diet, it's very, very frustrating. So we know right now that surgical treatment of obesity is really the only durable form of weight loss. We know it's relatively safe. We know that primarily we at Pikeville Medical Center do this to reduce or eliminate comorbid conditions that go along with obesity, those consequences of obesity that we talked about earlier. A little bit about the inclusion criteria for surgery. Back in 1991, the NIH put forth guidelines for bariatric surgeons as to who should probably have surgery. And what they came up with was anybody with a BMI, remember body mass index, dividing your height and your weight, over 35, with a significant comorbid condition like diabetes, hypertension, coronary disease, those kinds of medical problems, should have bariatric surgery to help them lose weight and, more importantly, to lose their medical problems. We know that anybody with a BMI over 40 is going to shorten their life if they do not lose weight. And so anybody with a BMI over 40, the NIH stated that we as bariatric surgeons and in the bariatric community could operate on those patients with or without medical problems. There is a new, small, growing group of people who have a BMI of greater than 30 who the FDA has approved the lap band for severe diabetes. Those particular operations are not yet paid for by insurance, and so there's very few of these being done in this country at this time. We define the benefits of weight loss surgery really in two distinct categories. One is the improvement or elimination or prevention of medical problems. We are really interested in seeing people lose their medicines, stop taking their insulin, get back on track in terms of health, and that's a big goal of weight loss surgery. The other, of course, side effect of weight loss surgery is weight loss. We see approximately 65 to 70% of excess body weight loss with sleeve and bypass. We see more than that with duodenal switch. We see a little bit less with laparoscopic adjustable gastric banding. So we know that with weight loss comes improvement in really quality of life. So patients who tell me they can't play with their grandchildren, they can't play with their children, they can't get into an airplane seat, they can't get into a booth, they can't sit in a chair without being concerned it might collapse. All of those things go away after weight loss surgery and success with weight loss. This slide actually depicts resolution of comorbid conditions after weight loss surgery. This slide was created from a number of different papers in approximately the year 2000 looking at resolution after bariatric surgery. We have done since this time multiple years of hundreds of thousands of weight loss procedures, and these numbers are even stronger today than they were back in 2000. Along with the benefits of weight loss surgery come risks, and they're real, and they do happen to some people. However, the risks of a severe major complication in the first 30 days after surgery is 1%. So it's very low. It's in some cases and in some populations much lower than that. These risks will be very carefully discussed with our patients prior to surgery so they understand the risks and wish to proceed with those risks. This slide depicts my first 1,200 cases and my complications. Most importantly, this slide is here to remind me to tell my patients that they need to know who their surgeon is. If you don't know who I am and you don't understand what my experience has been and what my complications have been, then you don't have all of your information. So make sure whoever you see for weight loss surgery, if you're interested, ask questions of that person's history, of that person's complication rate. Here at Pikeville Medical Center, we have a philosophy about weight loss surgery, and that is that we're here to perform surgery, but we're also here to keep you healthy in the long term. And I think the most important thing that we can do for our patients is to follow those patients after surgery. It is always important to see your physician on a very regular basis for the rest of your life if you've had weight loss surgery. We know that in the past, in the distant past, we had very poor follow-up and we didn't have good programs and good support structures for this. We now have excellent support structure. We follow our patients every 3 months for the first year, every 6 months for the second year, and yearly thereafter. We are very interested in making sure that you're healthy and that you're doing well, and that if you have a problem, we catch it early. And I think that's the most important piece to this. We have an extensive team of people who take care of our patients. I do not work in a vacuum. I have a coordinator who manages to take care of all of the facets of this program. We have psychologists, we have dietitians, we have nurse practitioners, we have support staff for insurance questions and problems, we have medical assistants and nurses. So we are here as a team to take care of you in a multidisciplinary fashion. A little bit about preoperative evaluation. It gets a bad rap sometimes. In order to get bariatric surgery, you must undergo a preoperative evaluation to ensure your safety in the operating room, your safety after surgery, and your overall long-term success. What we do with our preoperative evaluation is really a three-tiered system. We, number one, make sure that you're medically fit for surgery. Any medical problems that you have are evaluated very carefully, and we want to know the risk of doing surgery on somebody with diabetes and heart disease. So we'll ask you to undergo some medical treatment and some medical evaluation to ensure that you're safe, ultimately, for surgery. The second thing we do preoperatively is we want to make sure that you're fit psychologically. We send everybody to a psychologist. We want to make sure that you are understanding of the consequences of surgery and that you are fit in a mental health way to undergo surgery and the sequential follow-up that we need you to undergo. We look for mental health problems that are untreated so that we can get them treated before surgery. Many of our patients have mental health issues that are well treated and continue to be well treated. So it's just important that we make sure that you're fit for surgery in that fashion. The third thing we do is we educate in terms of the dietary changes that need to be made before and after surgery for ultimate success long-term and durability of weight loss. So we spend a great deal of time getting you prepared in this fashion by way of dietary education, by way of support groups, and by way of discussion with the nurse practitioners and myself. With all of these things together, we are assured as we possibly can be that you will do well after surgery. So I want to switch gears a little bit and talk to you about weight loss surgery that we perform at Pikeville Medical Center. The first operation I want to talk about is the Roux-en-Y gastric bypass. This operation's been around a long time. approximately 40 years. It's been done virtually the same way. There have been some small tweaks along the way to make it a little bit more efficacious. But in general, it's been a very solid operation. It was the standard of care in this country for many years. The lap band has come up and gotten more popular in the mid-2000s, and then has lost its popularity as sleeve gastrectomy has become more popular. But gastric bypass has stayed a tried and true operation. It involves creating a small gastric pouch of approximately 15 to 30 cc's and a limb of small bowel anywhere between 120 and 150 centimeters. It carries with it a restrictive component, meaning you can't eat very much when you have this operation, and a malabsorptive component. When you eat food, some of it is not well absorbed. This operation also carries with it a change in gut hormones that lead to a lack of hunger for quite some time. So it makes it easier to lose weight if you're not hungry after eating a very small meal. This operation is done through little incisions and is no longer done through a large incision.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
So the second operation I would like to talk to you about is sleeve gastrectomy. This operation is relatively new. It's being done in the United States for about 10 years. It is an operation that basically involves taking out most of the stomach and leaving a small tube of stomach. This creates a relative restriction of food so that you can only eat about 100 cc's of food at one time. It also causes significant hunger loss for the first year to 18 months. And again, that makes it relatively easy to lose weight because you don't feel hungry as you eat a very small meal. You feel full. The procedure allows for approximately 65 to 75% of excess body weight loss, and unlike gastric bypass, which usually leads to a 75% to 85% excess body weight loss. It is also done through small incisions, either one incision in your belly button or 4 to 5 small incisions in your upper abdomen.
The sleeve gastrectomy is a restrictive procedure, which limits the amount of food you can eat by reducing the size of your stomach. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
The next operation I'd like to talk to you about is the laparoscopic adjustable gastric band. This operation's been done in the world for many, many years and was approved in the United States many years ago. It gained popularity as a different operation from gastric bypass that was slightly less risky. We have found that this operation is not as efficacious for weight loss for the majority of people, and that excess weight loss is much less, between 30 and 50% excess body weight loss. The weight loss is slower. Indeed, it is an adjustable and reversible operation in that you can remove the lap band if you're unhappy or displeased with its results. It is considered a restrictive operation, although there are many things at play here, including some neurologic feedback of the stomach and those things that lead to early satiety after eating a small meal. This is also done through 4 to 5 small incisions in the upper abdomen.
The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The Realize band is introduced to the abdomen through a trocar. The Realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the Realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the Realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The Realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced to the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch restricts the amount of food you can eat before feeling full.
The next operation I'd like to discuss with you is the biliopancreatic diversion with duodenal switch. This operation has been done for quite a while in the world, has been done in the United Kingdom for some time for diabetics. It's an operation that we at Pikeville Medical Center do not offer unless one's BMI is greater than 50. It's a very complex operation that involves creating a very large sleeve gastrectomy of the stomach and also rearrangement of the small bowel for more malabsorption than the gastric bypass gives you, to allow for greater weight loss in patients that need to lose a significant amount of weight. So patients who need to lose 200 and 300 pounds, this operation is a very good choice. I will usually tell my patients that I'll discuss this operation with them if I feel as though they would benefit, and draw it in the office because it's relatively complex, and a video here would only be confusing to the layman. So I will skip over a video of this particular procedure to discuss this in the office with anyone who's interested. So a little bit about postoperative care. In general, when somebody comes into the hospital, they go to the operating room, they spend a couple hours in the operating room, they go upstairs to the 8th floor where we have our bariatric center, and they stay for 1 to 2 days, depending on what operation they had, what comorbid conditions they have, and how well they're feeling. At the end of those days, they'll go home, and they'll go home on a certain diet that has progressed over many weeks. We have approximately a 1 to 2 week recovery period where people can return to work and return to their life, and band fills get done at 1 month.
My name's Kayla Crusham. I'm one of the dietitians with the Weight Loss Surgery Center. I'll be talking to you today about some basic nutrition guidelines that we want you to abide by, certain requirements that are going to be necessary both before and after surgery. One of our overall goals with this process is to help you reclaim your life. There are certain things that are necessary in order for you to accomplish this. One of the things in particular, as part of your checklist, is your insurance might require you to complete a 6-month medically supervised diet. And that is, every insurance requires different things, but as one thing that you might be asked to do. Other things that we're going to talk about are our pre-op diet, post-op diet requirements, and how to accomplish the overall diet plan after surgery, which is a high protein, low carbohydrate, low fat diet. One of the items in our pre-surgical process is that we will ask you to complete a 1,600 calorie diet plan. This is accomplished by, on your initial visit, we'll give you a sheet of paper that helps break this down. The main reason for completing this diet plan is to help you create healthy diet behaviors. We want you to start getting in the habit of eating healthier foods, choosing healthier foods, and cutting out the junk food, which includes soda, any high-fat, high-carbohydrate foods that are not tolerated after surgery. The post-surgical nutrition requirements include a high-protein, low-fat, low-carbohydrate diet. This is going to be obtained by getting 70 to 90 grams of protein daily, 25 to 33 grams of fat daily, and 100 grams or less of carbohydrate daily. Another very important aspect of this diet is getting at least 64 ounces of fluid daily to ensure that you do not become dehydrated. Like with the pre-op diet, we ask that you have no carbonation in your diet. Other behaviors that we want you to get in the habit of are eating slowly, taking very small bites and chewing thoroughly. We ask that you eat and drink separately at meals, and you do not use a straw for 2 weeks, and limit any caffeine to no more than 12 ounces daily. The best way to accomplish your protein needs after surgery are through protein shakes. Now, a lot of times, people's nose are stuck up at these protein shakes, and I assure you that there are ways to make these taste better than what you have either tried in the past or what you can think that these shakes taste like. You are required to have at least 2 to 3 shakes daily, and that is up to 18 months after surgery to ensure that you reach your protein requirements. It is very hard to eat 70 to 90 grams of protein for a very long time after surgery. So these shakes are very critical for your safety, to ensure you do not become protein malnourished, and for overall weight loss success. There's numerous products on the market today to help with this requirement. You can use either milk or water to help make these. The only time you are limited with what you can put in these is your first week after surgery when you're on your clear liquid diet. Otherwise, you can use skim milk, and as you progress through the diet stages, you can add things in these shakes to ensure a better flavor. There are numerous pre-made protein shakes on the market today, but we do ask that you pay close attention to the nutrition label when selecting these items. There are certain shakes that are not considered bariatric friendly, and we do not want any reason for unintentional weight gain after surgery. There are a list of requirements that we've come up with to help you select a pre-made protein shake. We ask that these shakes have at least 20 grams of protein, they have less than 3 grams of fat, and no more than 10 grams of carbohydrate. This should make your selection with these much easier. In addition to protein shakes, you will be asked to take vitamins for the rest of your life. You're having a surgery that is malabsorptive, and we ask that you supplement these vitamins to ensure that you do not become deficient. The vitamins that you will be asked to take after surgery include a chewable multivitamin, a calcium chew with vitamin D and vitamin K, B1 or thiamine, vitamin B12, and for our female patients, you're asked to take vitamin C and iron. If you are pursuing the biliopancreatic diversion surgery, you will be asked to supplement additional vitamins, which include vitamin A B complex, vitamin D, and a probiotic. It is very important to take these vitamins for the rest of your life, as you do not want to become deficient in any of these vitamins. Deficiencies in these vitamins can cause irreversible damage to your body. The dietitians in our office are very knowledgeable about these things that we ask of you to do. If at any point in time you have a question over any point of this process, We encourage you to call our office at any time to get any answers that you need. There is no wrong questions. The only wrong questions are those that are not asked.
So you've heard a lot about weight loss surgery today, both the operations themselves, nutritional changes that need to be made, and about our program, as well as a lot about obesity and what the consequences of obesity are. If you are obese or morbidly obese, you have an interest in weight loss surgery, or you just have questions for us, we are happy and more than willing to come and discuss this with you. Thank you.
We hope this information has been helpful as you consider your options for weight loss surgery. If you have additional questions, feel free to contact Pikeville Medical Center's Weight Loss Surgery Department